Hi, this is Dr. Tao Chen, the chairman of Biomed AI from Taiwan. The topic I'm going to present today is the unique bone growth pattern on innovative laser-treated surface and heart tissue performance. Nowadays, the implant is a very popular treatment in dentistry. It is simple and straightforward in most of the cases. For example, this one, that we have the extraction and let the bone healed for about 4 months. And in this situation, allowed us to put the implant in, and then 2 months later, we can see the bone healed, and then we can start with the temporary or even with the final impression at this stage. However, we are not always that lucky. For example, from time to time, we will see the poor bone saturation like this. In this situation, it's not that easy. However, we need the better technique or the more experienced in this field. However, that if we can have a very good implant system with the built-in or pre-existing behavior that can help us to have the bone growth or remodeling on the surface, that can help us much easier to make the implant in this kind of situation. And the Biomed AI create a very unique PTL laser system that can make this implant has this kind of character. The PDL means the precision dimension laser. And this laser treatment can create a very unique microchannel on the surface compared to the SLA. That's a randomized roughness on the surface. It's regular with the channels. Because it's made with the laser, so without any chemical or particle involved, so the surface is extremely clean, without any residue of the chemical or particle. And from the laser treatment, we created the microchannel with the nanostructure on the surface, and this channel contain the three-dimensional structure is good for the cell growth and the differentiation. I know the microchannel is not that popular in dentistry. However, in the biological field, it's well explored system for cell culture and also some bioreactor for the tissue studies. And actually, in the biological world, that a lot of system contain this kind of smaller fluid passages. For example, the brain, lung, the kidney, intestine, and blood vessels. And by definition, the microchannel dimension is about 10 to 200 micrometers. And our microchannel is about 20 micrometers diameters. And these channels can serve the character for the transport process and can have the fluid intimidate contact the wall. And also if we have the cells attached on, we can have the particles or proteins attached to the cells. And also these channels can help maintaining system conditions with several ranges, including the temperature and the pH value. That's good for the cells survive in this system. And if these channels with the nanostructure can also help the cellular adhesion and the protein absorption. And also it can accelerate the microsphere flowing over this nanostructure that can accelerate the material exchanged and benefit for the cell growth. And because of the microchannel provide an excellent opportunity to maximize the surface area available for the cell attachment, and also enabling the good temperature regulation and the rapid exchange of the liquid media. In our size, the 20 micrometer is also good for the osteoblast and the endothelium cells attach and differentiate. This is our microchannel. In the first few hours with the culture, you can see the cell attached very, very fast on the nanostructure of this microchannel. And a few hours later, you can see the cell attach more and the growth very fast and spread. Compared to the other, for example, the ground and the SLA surfaces, the PDL surface have the much high efficiency of the cell attach, spreading, and grow. And the research from Dr. Natame from Thailand, he compared our microchannel with the BioHorizon microchannel. The BioHorizon is on the neck, and our microchannel is the full body of the implant. However, that we can see these two different microchannel. Our microchannel in size about 20 micrometers, and the BioHorizon is much smaller. It's less than 10. It's about 5 to 10 microns. And you can see for the osteoblast cell line, the our PDL surface have this much higher cell growth rate on the surface. And the research from Dr. Yu from Defense University from Taiwan, he co-cultured two different cell lines, the endothelium cell line and the osteoblast cell line on this culture system. And compared to the junction of this contact area, and to see how these two different cells attach and the growth and differentiate on the surface. He found the interesting thing is that on the PDL surface, in the day one, the first day, in few hours, he saw a lot of osteoblast cell line attached on the the channel form. The channel form on the surface. You can see the the green cell image on the surface. And 2 days later, in the day 3, you can see endothelium cell line from the tubing form. That's the differentiation sign for the endothelium cell line. You can see on the surface, it's very clear. We see the tubing formation of the endothelium. So the conclusion from this study showed that the PDL surface compared to the polished or smooth surface is have a much higher efficiency for the osteoblast and the endothelium cell to attach and grow. You can see alignment of this cell. The endothelium aligned is also match the groove form of the channels. And this study is worldwide finding. For example, the Jiao Tong University from China also have the similar finding. They have the micro nano pore surface that use the three-dimensional 3D printing technique to have the special chemical on the surface. He found this nano and the pore structure can benefit for the angiogenesis and also the osteogenesis to rapid osteointegration on the surface. So that's the similar finding. However, our surface is use the laser engraving technique to make the much tougher nano with the, the microchannel with the nano structure on the surface. How it behave on the in the real world. This is the case. We have the PDL implant in, and unfortunately, the patient suffered from the traffic accident. So you can see the center screw fractured and the implant be bended a little bit. So we have to remove that. So we use the piezo to remove this implant from the bone, and we can check how the bone growth on the surface. Okay, from this image, if we cut, if we see the uh, blowed up image from the thread, we can see the very clear image of the cell attachment or the collagen growth uh, on the surface and within the microchannel. You can see very clearly that a lot of cell-like or the collagen or some soft tissue within the microchannel. And from here, we can find the bone within the thread and see the layers of the bone structure in that area. Clearly, we can see four different layers. First is a basal layer, that's which we mentioned about the soft tissue and also the collagen-like material in the area of the microchannel. And also we have the intermediate layer on top of that. And on top of the intermediate layer, we see the soft calcified layers and also the hard calcified layers. It's well organized and integrated together in the very, very tight bone structure zone. And this is the image that we can see the first basal layer with the softer material and the intermediate area that can extend the softer material into the hard calcified tissue. And during the process, of course, we can see some dry, and the drying causes some crack. And from this crack, we can much easier to see the layers on the surface. The important thing is that we can see, even though it's been separated, however, that on the in this microchannel area, we still see a lot of soft tissue-like material very tightly attached to that. Oh, it's very like the Velcro fastener system that can really attach these two together, very, very tight. And this is a case of SLA surfaces that also have the accident about the fractured. So we have also taken it out from the bone. We see that the surface is totally different from what we see on the PDL surfaces. On these surfaces, we can see the collagen or the soft tissue like layers very, very thin. Some of them we can see that's completely separated like this. So this connection is not as tight as we see on the PDL surfaces. And this finding is very similar to to Dr. Davis in 2003. He found that the collagen can be seen to be distinct from the interfacial matrix that separate the collagen from the implant surfaces. That's the very unique character of the sandblast or the SLA surfaces. However, in the PDL, we can see it's tightly connected. So that can explain some early study we have in the animal, that we have the PDL implant and the SLA implant inside the pig mouth. And in the first month, when we harvest that and the process to see that under the microscope, during the processing, we see the PDL surface have very, very firm bone contact compared to the loose contact of the bone on the PDL surfaces. Even in the month 2, we still see the similar thing. Not until the third month, then we can see both of them have the good bone contact. That means for the traditional SA service, we have to wait 2 to 3 months before we do any further treatment. However, for PDL, we can wait much shorter time, to have the second stage, or the even if we want to do the immediate implant, also it's beneficial. And this phenomenon is really coincident to our finding on the electron microscope. And compare to the implant surface, implant bone contact to the real tooth situation, that we see that the significant different area is here. The PDL of the nature tooth have the good blood supply within the PDL. However, in the implant surface, we always see its lack of the blood supply on the junction. And in our PDL, because we have the microchannel, so for the microchannel, that can help as we mentioned before in the microchannel study, we provide the opportunity to maximize the surface area. That's first thing, to have the good temperature regulation, the rapid exchange of the improved media. That means this microchannel have the chance to have the better nutrition support and offer some media to exchange in this area. So it can compensate part of the real PDL function. How it worked in a real bone, we can see this is about 2 months healing after the tooth extraction. We can see the bone still very loose in this area. However, when we do the implant, 1 month and 2 months later, 3 months later, we can see the bone quickly formed around the implant. So as I mentioned before, that bone growth efficiency is much higher on the PDL surfaces. Sometimes we have to use the particulate bone or bone graft combined with the implant. And we also see, take this case for example, because of the severe perio problem, after extraction, we have to do some socket preservation. With the socket preservation, after 3.5 months later, we can see the bone grow, not very, or maybe only to 30 to 40%. However, in this situation, if we put a PDL implant in, 3 months, 6 months, and then 9 months later, we can see the bone really grow back in this area. And also, if we layering the bone particulate on the surface, we can see it's tightly contact. And 1 month, 2 months later, you can see the bone start growing. You can see the cortical bone growing out. And then 5 months later, you can see the bone really well formed on the surface. And this can be seen in a lot of cases, like this one, the very, very loose bone situation. However, with some bone graft, we can also see in only 2 months, the bone growed very well. Even though in this very, very thin bone situation, we can see this is the original bone level. And then this is 2 months later, you can see the bone grow already. And this is also the other cases showing the very similar result. Even in the very thin bone, after we expand the bone, either with the piezo, of course we can do a lot of things. Piezo is one thing, denser bird, or also the osteotome, the very classical way. After we enlarge it, we have the chance to put the implant in. In this situation, you can see this very thin and dense bone. when we split the bone, we put the implant in, we can see the bone is really split. However, that we can see 1 month, 2 months, and 4 months later, the bone chips is coming back. So we can really see the PDL surface is beneficial for the bone growth. If we have the good blood supplied around this area without any contamination, we can have a very, very high chance to get a successful result. And not only that, we can see one more interesting point. This case, we can see when we do the implant inside the sinus, this is the bone level, original bone level. However, that 5 months later, we can see the bone growing up. Of course, you say this is not the unique behavior because we found that in many implant situations that the bone grow. However, one thing, the interesting thing is that this is the result we saw before. However, that 3 years later, when the patient come back, the gum problem happened. We have to pull the second premolar out. At this moment, you can see the interesting result coming. This is the bone level been seen before, and this is 3 years later. We can see the bone keep growing in these 3 years. In the normal situation, because the pneumatic pressure inside the sinus, we always see the bone, especially the bone graft, being pressed because of the pressure. It decreases the level instead of grow in this area. However, in our situation, we can see the bone keep growing. This, we believe, that relate to the form of the microchannel that can leading the cell, the osteoblast cell, to some empty spaces, to the apex. Of course, the biohorizon that have the horizontal thing, the microchannel. I believe that we cannot have the similar situations ours. And this not only been seen in the sinus, in the apex area, we also see that in the crest area. For example, this case, in the original situation, the bone is very thin. It's about this level. And after we have the implant, 5 to 6 months later, we see this result. Just concentrate our attention in the crest area. We see still have some voids in this area. And also in the buccal area, we can see the bone is not that dense. However, 3 more months later, we can see the crest area have more bone coming out. And the buccal side bone quality get much denser. So we can see that the PDL surface is really provide a good environment for the bone keep growing. That can be seen in this situation. You can see the voice, and then a few months later, the bone coming out. And similar to a lot of situation like this and this, compared to the original. So we know that if we really want the bone grow in that area, even in the natured status, if the bone is too thin, we lack of the blood supply in this area, we will got the crack or the fenestration in this area, even in the real bone. If we have the implant in without the good blood supply, we usually will lack of the bone in this area. But a lot of cases I show that we really have we really got the bone grow back in this area. So we believe that in this area, because the PDL services we have, the laser treated microchannel area in this area. So beneficial for the new bone formation in this area. So that's why we always see the similar result coming out. Okay, you can see the thin bone here. In the very poor quality bone area, we have the new bone growing out. And also in the biological research field, we also find the channel can help the hematopoietic blood cells to differentiate. So if we can think about our PDL implant being inserted into the bone, that's the microchannel with the nanostructure in the bone marrow, can really create the environment for the bone attach and the differentiation. So it can be easily explained how it happened in this situation. We have the implant in, and a very real amount of the bone particulate inside, and a few months later, we can really see the bone growing back, because the PDL is the microchannel with the nanostructure inside the bone marrow. That really beneficial for the bone growth in this area. Just similar to this situation. Even though we have the bone graft, uh, 3 to 4 months later, we don't see too much bone. However, once we have the implant in, 3 months later, we have the very, very dense bone coming out. That's 1 year later, the bone completely come back. However, in some situation, in the early stage, we found one thing. If in a very dense bone, if we insert the insertion of the implant is too, the torque is too high, that when we want to get the so-called the good primary stability, the problem is that if too much pressure on this area, we found some bone resorption. And this happened in the early stage, because that time we didn't notice that the pressure is the problem of this PDL system. However, that if we wait longer time, we found this area, the bone can grow back. If we don't, we can maintain this area clean without any contamination. The bone can grow back. So in this situation, that's similar thing. In the dense bone, we found resorption in the earlier stage, and the bone grow back. Like this, it's a very dense bone in the initial stage, and then we found the resorption. The resorption, we believe that because this area need the blood supply, so they have the severe bone resorption first to create the environment for the bone to grow back. You can see it growing back in the later stage. The important thing is that at this moment, we have to keep the whole environment clean. So the other way to solve the problem is that we really face the very dense bone situation. We're better to find out a better protocol for that. For example, usually we have the main drill. The main drill, the last drill of the implant, usually that's the size smaller than the implant per se. However, in the denser bone, we need the tapping. Tapping is the size similar to the size of the implant, or sometimes it's even bigger if we really in the very, very tight bone. That we need a bigger size tap for to drilling the bone to allow the implant in. That in that situation, we can decrease the stress. So we have the protocol be mentioned in the brochure, that to mention in a denser bone, we suggest to have the tapping sometime to have the better result. In this situation, you can see in the tight bone, okay, we can have the better result of healing. For example, this one, when we have that the implant is very, very tight in the beginning, and then we can see the healing is much better. If we have too much stress, sometimes we'll get the reverse result. And also, we can not only the surface per se, we found that the structure, the design of the implant is also important. We have the dome shape of the apex, and we have the blunt end or trapezoid thread designed. That's important for some situation if we have the implant go into the sinus, that can have much less stress to damage the tissue around. Or this area, if it's very close to the channel, that if we have a blunt thread or the dome shape, we can have much safe way to have the implant in. For example, this one. In this situation, even you over talk a little bit, you still can save this situation from damaging the nerve. And all this situation you can see in the very thin bone situation in the for the sinus or for the channel. This design is very important. And combined with the tightly designed connector, including most taper and the other things, we make the connector very, very tight, and that can really offer the good stability. It's beneficial for the immediate implant immediate loading. In this situation, you can see this case here that we can see some void, and when we have the bone particulate in here, because of stability, that we have much less stress for the surrounding tissue than bone particulate. So you can see during the healing stage, you can stabilize the bone growth around this area. And for many cases, we do that in the immediate implant, it's quite successful. And also we know that this the structure of this implant design is good for the immediate loading, and also it can be used in the 4 or 6 implant for immediate loading cases. And last but not least, important character is that from Dr. Andrea Ionescu from Milan, Italy. He used a very, very special biofilm culture system to test the biofilm formed in different treated implant surface. For example, they have the sandblasted, polished, machined, and also the laser treated surfaces. All these surfaces be cultured in the bioreactor, mimic that the reality of the tooth structure to have the biofilm formed on these surfaces. The result show that, of course, the sandblast surface have the highest biofilm amount, and the polished machine have the less. That's we know that before. However, in the laser treated surfaces, we found that there's much less biofilm amount compared to the others. And our PDL is the least during the research period. And this design come out some later the implant design, because the rough surface usually can is good for the biofilm, but it's bad for the implant result. So usually we have the machine surface on the top, on the crest area, to prevent the biofilm invasion. However, in our situation, we have the machined surface, and our laser treated surface has the least, I mean, at least less biofilm accumulation compared to the other, the sandblast or SLA. So it really have the cell existing bacteria resistant. That's also good for the implant result. So that's the introduction today for our PDL services. However, that we still have more to find and more to offer to you. And you can, from this presentation, you can find uh, our implants is really unique and different from the other available implant in the market. Not only the thread design, important thing is less created microchannel with the nanostructure. That's very, very good for the implant process. If you can have the chance, you can really try to some poor bone situation. You will really find the beneficial from this PDL laser treated service. Thank you. This is the presentation for today.